and facilities, private, public, faith-based organization, talking to us about leadership and how it has helped in their quality improvement journey. So to start us off, we'll start with Dr. Kerry Jones. Dr. Kerry Jones is a consultant anesthesiology based in the UK, but she's been supporting quite a number of projects in Kenya and Future Health and Lead for Q4A program. And I'll let Dr. Kerry tell us more about herself, but she's been supporting quite a lot of work in Nanyuki and Laikipia regions. And she'll let us know where else she's supported. So Dr. Kerry, welcome to the session.
Thank you very much. Can I just check you can hear me okay and see my slides?
Yes, I can hear you. I can see your slides.
Thank you very much. Thank you, Rhoda. And first of all, can I say thank you so much for inviting me. I feel really privileged to be asked to speak, and I've been present at the other webinars this week, and they've been really excellent, and I've learned a lot. So just as a brief introduction, as Rhoda said, I'm a retired anesthesiologist, but I have had a big interest in quality improvement and innovation in the UK, and have been working particularly with Laikipia County for 12 years now. And my partner doing the work there is Dr. Tim Panga, who I hope is joining us, who's the CEO there. And also he's our lead for our QI work and leadership work in Kenya. So I'm going to present a few slides, and then he's going to discuss the impact of the work locally and how it felt. So first of all, to introduce the partnership, then I'll talk about the leadership, and then we can have that discussion. So we came to Laikipia by invitation when a young junior doctor from my hospital in England met Dr. Nadanya, who's the fantastic surgeon at Nanyuki Hospital, and they got talking, and he was struggling with his trauma workload with no equipment, and people across the board with skills that he wanted to upgrade. So she arranged for a team of us to come out to Laikipia to work with him. We formed a health partnership then after the first successful project between Nanyuki, and then Nyahururu joined as well with my hospital in England, Torbay Hospital. It's in the southwest. We formed a charity which is called Future Health Africa, and that enabled us to apply for some grants from our UK Aid Department for International Development. So we continued with the trauma surgery, but particularly we developed the course recognition and assessment of the sick patient, GRASP-IT, which I think some of you may be quite familiar with because it's spread to other hospitals, particularly to Kenyatta. And then with successful grants, we were able to support Nanyuki's wish to establish their emergency department. They had a building, but nothing in it. And we did training in first aid and first responders. We introduced concepts of patient safety. We did some work on rehab and some primary trauma course training in trauma management. We brought some other projects as well, smaller projects. And we with the grants that we had, we funded some reciprocal visits. Second from the left, there's Dr. Njoroge, who was became the Minister of Health in Laikipia. So we were doing all this work, but grants are limited, and we were thinking, what next? We wanted to develop.
Sorry, Kerry.
Yeah.
Your slides are not rolling; they're not moving. We're still on the first slide.
Ah, okay. They're moving at my end. I'm so sorry. I don't know what's happening there. Let me just try to It was working earlier on, was it not? Yeah. Can you see it now? Are you able to see the slides now?
It's still on the first slide.
Okay, so I don't know what's happened there.
On my side, I can see them moving. Could there be?
It's still on the cover slide. It's not yet.
Yeah, I'm sure I'm seeing
to the
UK
second part.
8 grants
Maybe,
2012.
oh, you can see them moving.
Yes.
Oh, yeah,
Okay.
now I can see it.
Yes.
Right.
Yeah.
Okay, fine. So we were thinking after these various projects and the grant was over, what do? We wanted to leave something sustainable behind and to to support Laikipia to progress as they wanted to, irrespective of our input or grants. So we thought, what can we do? So we proposed trialing a course in quality improvement and leadership skills. And we got a further grant and started the Springboard program in 5 years ago now. So the Springboard program is an active learning course over 2 5-day courses, so 10 days altogether. And it was designed by some colleagues, real experts in the UK, who've done a lot of this kind of work. And on each course, we've taken 24 participants, different cadres, who learn the skills through actually doing QI projects in teams in their own workplace. And we think that's really important. And the course is blended theory and practice. And you've heard about the QI tools and so on. And we've followed that, and we followed a particular pattern of identifying the problem, the stakeholders, looking at the current state, creating goals, looking at future state, and then designing interventions using PDSA cycles to the usual QI sort of methods. But within it, we've also embedded leadership. And the reason for this was articulated so many years ago, 70 years ago, by Duran in his quality handbook, saying that every individual in the workplace needs to take responsibility for QI, and if staff are not empowered to do so, results are limited. So we gave thought to what does this empowerment mean. So we feel it means knowing how to manage change, how to build teams, to create a culture for improvement, to influence others, show compassion, and much, much more. And it's not simply just a bag of QI tools to be applied, because all of these other things really need to be considered. We were very lucky in the picture, which I hope you can see. There is Dr. Kilonzo, who's a consultant pediatrician in Nanyuki, who was at the time the medical superintendent. And he gave a great personal example of how he was willing to get down with other members of the team and really try and solve problems. This was a team building game, but his leadership at that point was really crucial to us. He was showing by example that we could all do it together. So we developed a curriculum and the leadership curriculum, but we taught it directly related to the QI projects that people were doing during the course. And this is a long list of some of the topics that we covered, but it's too big to go through, but really it focuses on people at work, what their personalities are, what their leadership styles are, understanding yourself, what the differences between leadership and management are. Interestingly, we're going to be bringing out compassion as a good feature of leadership in future, which I think is really important. We talk about being effective, we talk about listening, emotional intelligence, coaching, and so on. You can see that's a long list. And also importantly, managing change and managing conflict in the workplace environment, because as soon as you start to introduce change, try to introduce change, it becomes an issue, as we all know. So have we been successful? Well, this was our first 3 projects that I am happy to say have sustained since the very beginning. One was hand washing, and everyone washes their hands as they come in through the hospital gate now. All the patients have unique identifiers for patient safety, and there was a program for improving prescribing on the children's ward. This was in Nyahururu, where this young intern and the team she was working with did a fantastic job of analysing why a baby died when it was an unnecessary death, and they all grew enormously in their confidence and feeling that they knew how to solve this problem through the course. We have many other examples. I can't show you them all. Now, when you talk about leadership,
so my name is Karoki. My other name is
there are some people who are just born leaders, and this is one of them. I'll just show you a tiny little bit. This is Karoki, who's she'll tell you who she is now. I'm sorry the picture doesn't quite come on. Where?
So my name is Karoki. My other name is Grace. I work in Laikipia County. I'm a pediatric nurse in charge of the pediatric unit. And when I came to Nanyuki, I was trained on the Springboard program. Springboard program helps us identify the major gaps and the projects to improve them, and also to sharpen our leadership skills. So I realized in the pediatric unit, the dose volumes or the calculated doses were too small, and it was difficult for the nurses to get the correct dose volume. So with the formula that maybe later I will share, I started to implement it. And the simple formula was to get the correct dose volumes so that the children get the right doses that are not toxic to their kidneys or the liver. So the project was to calculate the dose volumes. I provided a very simple formula that could help us calculate the dose volumes.
So I'll just stop it there because it's long, but you notice that she's speaking. This is what she has done. It's not what we have suggested, but she has really taken this training on and taken ownership of the project. So I just want to just show you the end of this.
Part of our able CEO, I think I've done good work in Laikipia County, and I would advocate most people in senior management or at the service provision level be trained on this Springboard, because personally I feel it's the best thing that ever happened to us. Because I believe my key word is, if you can't do great things, do those great things in a greater way.
Mm-hmm.
Thank you.
So that's Karoki, who's a fantastic leader, and she really has gone on to do many other things. And here, the picture on the left, you see she's presenting at the International Forum on Quality and Safety, her QI project in London a couple of years ago, and it was one of the commended posters. So she's really developed through this. So I talk about enjoyment at work. We can only get that if we feel empowered, and this was one of the teams really making a breakthrough in their QI project. And you see Dr. Panga there in the background, who's about to speak to you and give his perspective on all of this. We hope to continue work with Laikipia at some stage. They've had a lot of difficulties locally, politically with the hospital, so we're paused at the moment, both due to that and due to COVID and no grants at the moment. We recognise the need for training of trainers and formal training of coaches and mentors in Kenya. While we can't come at the moment, we're going to be doing some work with LVCT Health, who I think you're going to hear from tomorrow, on QI at community health unit level in Migori, and we're working together on that, and we're hoping to carry on with our work, possibly some work in Uganda at some stage. So partnerships are really important. I think can be really helpful, but everything should obviously be locally owned and locally delivered, and that's very much our aim. But it's great seeing things grow in Kenya, including particularly the Society for Quality Healthcare in Kenya, which Dr. Okitoy and others have set up recently. It's a fantastic initiative, and we look forward to working with you more in the future if we can be of any service to you. So that's it for my slides. I don't know, Dr. Panga, are you? I don't know if Dr. Panga's there, because I'd like him to follow on now if he is, to be able to discuss how the project felt from their perspective, and particularly on the leadership elements. Thank you.
Thank you, Kerry. Thank you, Dr. Kerry Jones. Dr. Panga has just joined. Dr. Panga, would you like to go next? And then we'll have Dr. Faith Lele. And after that, we'll have Dr. Frederick Kimemia.
Thank you so much, Dr. Kalondu. Sorry, I missed a bit of Dr. Kerry's presentation. I really want to just add that our journey on quality improvement has really been a journey that had several phases, where we really just started by wanting to provide the best care for people under us with the clinical care that we provide, the orthopedic projects, all other projects. But then we realized that we needed to change our processes, and we adopted, as Dr. Kerry might have already said, the IHI model for improvement, but adapted it to our local setting by doing a bespoke springboard course that has two parts. She must have already talked about it. The first bit is the actual science of improvement and doing the tests of change in issues that are identified by teams on the ground, and these teams go on to during the period of 1 week to test what they think is will lead to a change, and to change if actually any change that we are making is an improvement to our system. And then beyond that 1 week, we will go on and keep on improving further. We've had several projects within the 2 hospitals in Laikipia County. And for example, in one hospital, we've had way before the COVID era worked on our hand washing practices, both for health workers and for visitors coming into the hospital. And that has endured on. It's now a common practice. One very difficult one that we tried to work on was to improve the flow of patients who are attending unscheduled clinics. Commonly, as you know, is our outpatient clinic, and it was quite a challenge addressing the flow issue. As you'll know, most hospitals will have challenges with that, both public and private. But we really tested the journey for the patient. Then others were better patient communication in the context of any care setting. But in this one, we focused on radiology patients who need ultrasound, and what could we improve so that we don't inconvenience the patients, for example, who are required to have a full bladder just before an ultrasound procedure is done, if that was what the team found necessary, such things. And finally, all pain management in obstetrics. And there are also some things in the sister hospital, Nyahururu, which work well on the lab, the some the emergency department, which we've been sharing across. So basically, once we were done with the first phase, the foundation phase of the springboard, then the same team now will focus on more of leadership, on how to sustain improvement and how to make it part of the normal processes in the hospital. And there'll be views from different people. Some members who have been part of the second phase included some members of KNH, actually. One of the staff in the KNH was much part of that leadership bit of the course, and she's really been she's really taken much in depth into that bit. So the whole point is, by the end of it all, you have an all-round frontline healthcare professional who can test change and see if the change is an improvement, and have other skills that enables them to sustain what really makes a difference in the healthcare setting. I think that's what I'll add, if I'm not saying exactly what Dr. Kerry already talked about. Thank you.
Thank you very much, Dr. Timothy Panga, and it's good to hear from you again. All right, so one thing that Dr. Kerry Jones has brought up very clearly is that we cannot ignore or underplay the role of clinical leadership or leadership in quality improvement. And thank you, Kerry, for sharing with us the video of Grace Karoki, the pediatric nurse from Nanyuki. We've really enjoyed watching our own and a colleague being very excited about the leadership change or the change that they've brought to the institution and going further abroad to talk about it. So that's a really motivational factor for staff who are on the front line. And thank you for that opportunity that was awarded to her. We'd also like to thank the leadership for in that area for taking her through or nominating her to go for training. So I'd like now to go to Dr. Faith Lilly. Remember to put your questions in the Q&A section. We'll be able to address all of them at the end. And I hope Dr. Kerry, Dr. Panga, you'll not drop off, because we still have questions for you at the end. Dr. Lilly? Hello? Hello, Dr. Faith Lilly. Hello, Dr. Lilly. We can't hear you.
Hello, can you hear me?
Yes, we can hear you.
You can hear me and you can see my slides.
Great. Okay. So Dr. Faith Lilly is from Kijabe Hospital, and she'll be taking us through some of the work that they've been doing in quality and safety at Kijabe Hospital. So this will be the faith-based organization aspect that we're talking about. Karibu, Dr. Lilly.
Okay, thank you. Can you hear me?
Yes, we can hear you.
Okay. So saying, thank you for the introduction. So I will share a bit of our Kijabe journey. I am a family physician and the quality health and safety manager, and the quality and safety department started off in Kijabe Hospital officially last year. Time like this, it's 1 year old. But back in 2013, there was what was known as the Quality Monitoring Assessment and Evaluation Team, QMAT. That was from 2013 to 2017. That was really looking at assessments and still quality improvement with a view. It was primarily for NHIF, and that time, I think just how it was implemented in the hospital was not friendly. It was thought by staff as very punitive, and it was quite non-productive at that point, and that stopped. Then what happened thereafter was two key things. A leadership shift in what they thought of quality, and culture change. Let me speak fast on the culture change. Coming up from 2015 to 2017, the hospital went through a time where there were a couple of advance and agenda or to build a culture of quality without building a culture of trust. The hospital cleaner needs to
Sorry. Sorry, Dr. Lele, you seem to be breaking off. I'm not sure whether it's on my side, but you seem to be breaking off a bit. Okay, sorry, we apologize for that. We seem to have network challenges with from Dr. Lele's end. So we'll give a few minutes to be able to get some stable network. She seems to have also dropped off. So next we'd like to go to our main speaker, who was Dr. Frederick Kimemia. Good afternoon, Dr. Frederick Kimemia.
Afternoon. Are you able to hear me now?
Yes, we can hear you.
Okay.
Do you have any slides you'd like to share?
Yes, I can now.
Okay, we can go, and then once you can go ahead. Once Dr. Lele gets a bit stable, we'll be able to get her back on board just after your presentation.
And I think, sorry for that. I've worked in Kijabe and network is not usually very good. Maybe it's network issues, but let me share my screen.
Yes.
And then, yep. So are you able to see it?
Yes, we are able to see your screen. So karibu sana, Dr. Kimemia, to today's session. We're talking about leadership in quality improvement, for quality improvement. Na karibu sana, you can start off the session.
Hi, everyone. I am privileged to be with you this afternoon. I was able to listen in to Kerry's presentation and Lele, and I'm excited for this exercise. I My name is Frederick Kimemia, and I teach healthcare management at Kenya Methodist University. I'm also a founder director of Wired for Excellence. It's a mentorship program for healthcare leaders and managers in Kenya. And I also serve as the secretary of Health System Management Association, or HESMA. Some of you may know that we had a situation at KNH, and I remember our role in the association is to ensure that we have well-trained and well-empowered healthcare leaders in healthcare facilities. And I'm excited now to come on board and facilitate this, because our desire, the association, is to see the best out of KNH, and we are so happy for what now we are seeing. And now we have leadership that is taking initiative on improving healthcare services and making sure that you are responding to the needs of the population. So hongera KNH for the kind of work you're doing, and the department that is involved with quality, even inviting us and the rest, and having an opportunity to share the ideas and to share across the board. It's a plus for you. So that is just my general introduction. I want to open my presentation by just important determination. Quality management should not be, and I would start with the last one, should not be a program. Some of us think it's a program within the hospital, it's a division, it's a department. It should be a strategy, a way of doing business, and that is based on shows and quite cited by many writers, that quality management should be a way of doing things, a lifestyle, a strategy. It's a way of managing and looking at organization and its activities. And like I correctly shared, we are very, very happy that as KNH, you're thinking about having this strategy as a way of you're doing things. Quality management or quality leadership is also a set of systematic activities carried out by the entire organizations, making sure that there is efficiency and effectiveness, so that you can be able to achieve your objectives. And our objectives in healthcare is just to make sure that we have quality healthcare, safe healthcare, and healthcare that is accessible to all. So, and I'm hoping this is the attempt of KNH and for us all, just to ensure that we carry all these activities of our department, but for the purpose of the whole healthcare organization. And the first one I started with is that quality management or quality leadership is an attempt to embed all the qualities or aspects of the organizations. Aspects of organization could mean even the people who are within the organization, the staff, the structures, the customers, the employees, and also the suppliers, just making sure that everything is embedded together. So these are very, very important determinations, even as we're thinking about quality in leadership, quality in management, and all the aspects of the organizations. Leaders and leadership are supposed to make this happen. We are supposed to enjoy, and organizations that are putting quality as their important parameter. So, and quality leadership or quality management objectives should be able to connect the understanding of its activities to daily work. So leadership would now move all the quality initiatives, quality improvement activities into the long-term goals of the organization. So KNH now is putting these activities into the long-term goals. And what we're saying, quality management doesn't just focus on the outputs and the outcomes. We look at the goals. What are the long-term goals? And that's where leadership comes, because managers or quality improvement teams will probably look at the immediate output and the immediate outcome. But quality leadership in quality means that all the leaders in the organization are looking at the long-term goals. We are also saying that the objective is to think of people as people. Leaders who drive quality would see beyond titles beyond organization charts. And this the best standard that organization must be able to look at, not just the titles of individuals, not just the organizational chart, but look at people as people. People means that all the employees, all the customers are now valued as people. We must look beyond the leader. So leadership qualities must be engaged in looking at not the leader themselves. Leaders could be liked or favored, but the correct leadership would try to look at what are these issues that encourage employees to deliver quality. Issues to do with loyalty. Sworn soldiers, what we call sworn soldiers. Leaders would produce sworn soldiers. I run as an association that has about 70 volunteers, and these volunteers are in different technical working groups. And I see the determination that they have. I see the commitment they have. And what I usually see is that loyalty, or sworn soldiers who have been created from our leadership. And the leadership at KNH must look beyond just to be popular. They must look towards creating a mass and a number of employees, committed employees who look beyond just the activities, look beyond the activities. They are sworn to quality. They are sworn soldiers who deliver qualities and recognize their jobs and their opportunities as ways of achieving their goals. We also say that objectives of the best leadership of 21st century is that they must be thrilled when QIT and work improvement team members achieve great things. I'm waiting to see KNH inviting us, and I know you had one these early days there where you are giving awards on quality. You have quality awards. We are looking at how we are going to celebrate these wins, the quick wins. We have quality improvement teams and work improvement teams. How can we recognize this? So good leadership will be looking at how are we going to achieve great things by now just celebrating what we are able to achieve now. And lastly, this is an objective of quality, a leader in quality would think about empowering people through honest and transparent means. So a manager will parcel out information and try to honestly drive quality-related activities through transparency and honesty. They will empower leaders or managers who are bringing in quality. They will empower them. They will give this information personally. They will promote those healthcare workers or healthcare managers who are interested in quality. And I think during the previous presentation, you must have heard of a quality management system. And if you look at the top most important one when you're thinking about quality design is the leadership development. And I'll mention a little bit about that because I think I don't have a lot of time. So quality management system has a leader or leadership development as part of its important ingredient. So we have quality design. You move from quality design, you measure and you improve. So this is the standard quality management system or the process. And I will also share this because this is also very important. I was looking at the models of quality improvement. Good leaders will not just think about the QIT or the work improvement teams, but you will look at the whole organization in general. And what I just mentioned is that you must look at the technical performance of the organization, issues to do with access to service, effectiveness of your services, the interpersonal relationships in your organization, the choices of services, issues to do with efficiency, continuity, and these are the generally agreed models of quality. So a leader, good leader or leadership in quality improvement will not just look at one area per se. They will look at certain indicators within these models of healthcare services that will actually impact on quality. And I think some of you are familiar with this. sometimes we just look at effectiveness. Sometimes we just look at the access to services or the continuity of care. But a good leadership strategy will just look at all these in terms of what are we getting in our organization as it relates to these models. I was to share this because while you're designing quality in a healthcare organization like KNH, the function of designing and implementing will probably be allocated to the quality improvement teams and the work improvement teams and the quality improvement teams. Those are the ones who carry out the day-to-day activities of quality. And I think some of you are involved in that. But when you look at the design itself, a good leader in such an organization like KNH, and leaders, I'm not just saying is the person in position of authority, but if you're going to lead in improving quality, you must see yourself in this whole process. You must look at what is that the client wants, what are their needs, how do we develop products that impact on quality for our patients, and how do we operationalize and we come up with models. And I was very impressed to hear Kerry sharing about what Nuki is doing and small steps that could be geared towards quality. And I think Lerey was also sharing that from KNH. But as a model, we need to think about what is it as a leader am I going to do, or in position of leadership, or in position of influence. What is it that we're going to prioritize? But we must always think about what are the client needs. What are the clients, first of all? Who are our clients? What their needs are? We develop products that are aimed at meeting those needs, and we come up with models that are intended to meet that. I say this in the process of designing quality improvement programs. There is one most important activity, and I'm not going to mention the rest, but there is an intentional leadership development. So an organization will come up with a leadership development for quality, which is sometimes lacking because we leave everything else to be done by the department that is in charge of quality. We leave everything else to be done by the teams, by the work improvement teams, by the people who are in charge of quality. But in terms of leadership, we do not come up with an intentional leadership development program. So how do leaders apply quality improvement programs? So, and we can use this program to, like I say, to identify who the customers are. You already know who your customers are, and you discover customer needs. We will be sharing it as to how and come up with develop and communicate quality standards, come up, measure and monitor quality standards, and communicate the results to the users of healthcare. Some of the key activities that could be very effective for you to be able to discover customer needs, like what I said, you could also do your customers' feedback. Customers will keep on changing. Collect a list of needs in their language and analyze them and translate these needs into organizational language. So KNH has its own organizational language. We also are in organizations that we have organizational language. Translate your needs into language your employees can be able to understand. And then lastly, but not even most importantly is to come up with the measurement standards. So you are aware that we have to measure what we are doing, because if you're not able to measure that, you will not be able to achieve a lot. And I am so much impressed by Kenya Quality Standards. It's an initiative of some of our people that we know, that forever in our organizations, but also generally in healthcare, we have to emphasize on ensuring that we have measurement standards, and measurement standards that are very objective. At KNH, hospital like KNH, we can get an external person to help you come up with standards that you can be able to measure, that is internationally recognized, or something that based on the needs that you come up with. Sorry, a little bit about practicability. I know you are involved in picking up customer service. You could do market research, looking at what other people are saying in the general public, not just the patients who are coming to your hospital, but what about the general public who are not coming to your hospital? What are they saying? Tracking these customer complaints, leaders must ensure that this is done all the time. Employees with special knowledge on customers, sales services, coming up with meetings or personal visits to customer locations. I'm here to see maybe KNH or any other hospital going to the villages, going to customers and looking at why they are not coming or why they are coming and what could be working out well. Something we probably not do a lot is looking at the competitors, government organizations. You also have competitors. Now we have many referral hospitals coming up. So what are the competitors and what are their products? And also changing in national and regional regulations that would identify these opportunities for us to be able to deliver quality services to our people. And lastly, as leaders, we must be able to, leaders, I do not mean the CEO. Leaders, I don't mean the unit in charges. Leaders, I mean, if you are sworn a follower of quality, you are providing leadership in quality improvement. Some of us are very particular with quality improvements. And I think that's the reason that's why you're in this meeting, that we are sworn followers or believers in quality. So we have roles, and the three have actually divided them in three categories. You have to define your standards, your quality standards, and set the levels that are expected. So when we have deaths, when we have complications, those are not acceptable. So you come up with the standards that you say, for this area, these are our standards. And I know you have done that in theory, but in practice, what we want to see is that we've had complaints. So this is a standard, we want to reduce that. So and then I know somebody said, I think it must be one from Dr. Lele's presentation or Dr. Kerry, that we must come up with processes, inputs and processes and desired results, both at short term, medium term, and long term. What are these inputs? What are the processes that we are putting in place? As in leadership, we have to come up with this. And lastly, determine the indicators to measure and monitor. And I think we must have standards. As leaders, we cannot accept the status quo. So we lead from the front. We lead by saying this is what our standards are, and we're not going to accept anything below this. So I am expecting to see maybe even in the future pronouncement from leaders or managers of organizations openly saying that this is the quality we are hearing, these are the standards we have now, but we will move it to this level, and these are unacceptable. And those are the ones that we call standards. We say in this organization, in KNH, we do not want to hear of this. And I must applaud what we are hearing from KNH. I'm actually an outside stakeholder, but the complaints, the challenges that we used to hear at KNH, now they're almost done. It's not to say that you have nothing, but you have tackled on most of the complaints, or almost the challenges that we are hearing. So my belief is that you set a standard, and based on those standards, we've been able to work. The quality improvement team or the quality management team has been able to improve on those, so that we have reduced on the complaints of wrong patients being operated on. We have reduced on the complaints of patients. We have seen very good results from KNH now, and we hope we are going to achieve that. So lastly, on my presentation is that leader will determine the standards of quality based on, like what I said, input processes and standards. But please do not forget that a leader must always refer to the policies, must always refer to the protocols, must always refer to clinical practice guidelines. I had somebody say that about Nanyuki, standing orders, clinical pathways, rules and regulations, algorithms, job descriptions. Job descriptions are a form of quality leadership tools. So job descriptions and qualifications, and lastly, standard operating procedures. So I want to thank you, but my takeaway home is that as an organization or as leaders of quality, we must always think, what is it that we are not doing well, and what is it that we can accept, and what are we going to do about that, what we cannot accept. And as leaders, we must not accept the status quo. We are not going to accept cases of like patients complaining and accept it. We're having challenges with death that can be avoidable and accept it. So as leaders, we must generate an acceptable minimum and work on improving what we can improve during our time. And I want to thank you, Roger, and the rest of the participants. Sorry, I've taken more than the 7 minutes required, but it's my wish and my hope that we are going to be sworn believers or sworn and loyal believers of quality, because this is what will keep our healthcare, all our health system standards and quality going up every day. Thank you so much.
Thank you. Thank you, Frederick, for that wonderful presentation. We appreciate you and we thank you for that. And one thing I've taken on very clearly is the customer, the client's needs, the customer's needs. It's one thing that you stressed very clearly. Development of standards, we must have standards and we must have indicators that we measure. You also talked about leadership, thinking of people as people and looking beyond being liked as a leader. You talked about empowering people, empowering your staff. So thank you for that. I hope you'll not drop off, but we'll continue throughout the session to have Q&A session with you. There's a comment from Odor Otieno, and he's saying leadership or management, that is, are responsible for everything in the organization, especially everything that goes wrong. That is from Paul Neal. And quality improvement is that leadership instrument to ensure everything goes right. Thank you, Odor, for that. It's true, quality improvement is the instrument that leadership should use to ensure everything goes right. We appreciate you for that comment. Thank you very much. So I'd love to see from the participants in the Q&A session, as Dr. Lelei puts up her slides, has the leadership in your area supported you? Do you feel that in your facility, you've had leadership support in terms of quality improvement? And in what way did they support you? There are various ways in which leadership, from Dr. Keris, Dr. Panga, Dr. Kimemia, and what Dr. Lelei had briefly started to tell us about. We've learned that there are various ways in which the leadership can support you. One is by taking you for training. Two is by being interested in the work that you're doing as a quality improver or as a frontline worker. Three is by giving you a voice. Once the doors are open and you can approach the management and tell them, I feel that, or I think we can do this better, or we can calculate the dosages. Like you can see in Grace Karoki's situation, they were able to just change something small, like calculating the pediatric doses to avoid underdosing of children. And then the leaders can also celebrate the staff. Where there's a small change, celebrate that staff or reward the staff. So let us know in the Q&A session whether the leadership in your department or in your area or in your facility has been able to support you to be able to be a voice of change and to be able to bring about quality improvements in your department. Dr. Lelei, you can continue with your presentation. Sorry about the network challenges. Sorry about that. And then Milano Cheng from Chogoria will be coming in next.
Again, I'd like to apologize for my challenges in network. I hope it is now better and you can hear me. I won't do video to facilitate that. I don't know where I had last dropped off, but I thought to probably start from this slide because I think besides the leadership that has been talked about a lot, I wanted to, I don't know if you had heard me talk about the section on culture change and there being an enabling environment where those who are not considered leaders, in quotes, like the cleaners, the nurses, the morgue attendants, the caterer, those people who see things from outside and can pick out things can actually approach those who are defined as leaders traditionally, like the HODs, and actually mention something and say, I think something is not going right here, without fear of retaliation or fear of anything else. But having a culture that considers everyone as a team, that considers everyone as valuable, that considers everyone's input as instrumental in providing quality of care. And I think this was a very useful process that the hospital went through that then gave us a good platform to be able to engage honestly on different issues. So I just thought I would share 4 examples of projects that were done last year in collaboration with an institution that offered to capacity build different team members. Again, the teams that were in the different QI projects were the people came from different teams. They were all multidisciplinary teams. Again, just trying to reflect the idea that everyone's input is valuable and can be worked on. So for instance, one of the projects was to improve incident reporting of adverse events in the pediatrics department. One of my favorite stories about those projects was one of the members of this team was a HR assistant, someone in the HR, and she's actually the one who gave a suggestion of how the incident reporting could be done. There is a system in the hospital where we anonymously vote for Employee of the Year using an SMS system, and she's the one who suggested, can we use the SMS system that's anonymous to increase incident reporting of adverse events? And the project really took off really well, and the different adverse events reported were acted upon, different issues were raised that were acted upon. And actually this same tool is now being used for a second project that's now running within the lab, trying to highlight the different issues that go on in the lab and how they can be worked on. A different project that was worked on was reducing internal referrals waiting time, because I'm in the main Kijabe hospital and we do have 3 satellite facilities. So the question was, how do we reduce the waiting time from what I think was an average of 4 hours to 1 hour within time? And again, different members came together to try and work on that. A third project was 100% complete antibiotic prescriptions, the correct dose, the correct time, the correct duration, all that to 100%. And the last example I will give is reducing admission time for elective patients. So we'd have patients who would come and be told, you're waiting, your surgery, that your next slot for surgery will be due in, say, 6 months or 3 months, and collaboratively working to reduce that. And I'd like to highlight what the previous speaker has talked about on leadership, Mr. Kimemia, that all this has to be started off. The board and the SMT need to, SMT I mean by senior management, need to find a way to communicate their vision on QI and build capacity for as many people in the hospital as possible to catch the vision of quality improvement, so that it is not something about the department of quality. It is not something about the HODs. It is not something about quality assurance, like when you're thinking of accreditations or certifications. There needs to be a way to ensure that everyone in the hospital catches this vision and drive, so that it is everyone's business. It has to be everyone's business within the hospital. A second place where I would just like to mention has really helped the hospital grow and given the different departments in the hospital opportunities for micro changes, things that can be worked on within a week, within 2, and you can see sustainable change is in morbidities and mortality meetings. I had been to different hospitals where such meetings were feared. There were opportunities to blame people. There were opportunities to point fingers at the nursing department, at the doctors, at the cleaners. But when such meetings are conducted well, give opportunities for everyone to reflect on what has just happened, and very honestly come up with suggestions on what they think should happen, and chat away on how that should happen. And so in the hospital, we do have a way of categorizing mortalities. And in these different categorizations, there is a specific way we categorize deaths that we think are attributable to system issues. So for instance, there might be someone who came in with advanced cancer, and it was known that they were at their end of life and palliative care had been instituted, and when they came, they passed on. We will not audit that death the same way we will audit, say, a maternal mortality that we felt was due to PPH because there was no blood. So the deaths that are thought to be system mortalities, how do we capture those mortalities and have honest conversations? Or the right leg was operated on instead of the left leg. How do we do those audits in a productive manner that does not assign blame or point fingers to other people, but instead leads people to have honest conversations on what happened, where they need to be, and how to get there. And I think one of the important things is how the leadership of those departments carry it on, how the leadership carries on those conversations, how the root cause analyses are done, and the actions that are arrived at. I think my 5 minutes are up, and if there's room during the question and answer, I may be able to elaborate more on some of the different things we're doing. Thank you very much. And again, I apologize for my internet instability.
That's okay. Thank you, Dr. Lele, for your presentation. And we're excited about the work that you're doing at Kijabe, AIC Kijabe, and you brought out a very pertinent issue, organizational culture and leadership. It is a conversation that we need to have, especially in healthcare. Thank you for that. There's just one question, and maybe this you'll answer during the Q&A session, about somebody's asking how you could share how the 100% completion of antibiotic prescriptions was achieved. But you can answer that in the next 10 minutes. Now we'll let Milano Cheng from Chogoria share his experience with us. We'd love to learn from Chogoria also. Karibu, Milan.
Thank you. I don't know if you can see my screen.
Yes, we can see your screen, we can see your slides, and we can hear you very clear. Thank you.
Oh, thank you so much. It's very difficult to speak after every speaker has spoken, including the main speaker. Anyway, I'll try. Dr. Kimemia is my teacher, so I'll tread very carefully. So I want to speak about Chogoria's experience in leadership for quality improvement. Chogoria Hospital is a mission hospital. It's situated in Tharaka Nithi County. And it was established in 1922, and we are a 295 bed capacity hospital offering service to the people of Tharaka Nithi and its regions. So I want to quote a statement by somebody, and he says that there are only two types of healthcare organizations: those that have accepted quality improvement strategies and those that will. Leaders of today's healthcare organization are on a continuous journey to improve results, requiring a relentless focus on improving the underlying process of care delivery and leadership practices. Leadership in quality improvement is the surest avenue that provides compelling ideas to help create better place to work, practice medicine, and receive safe and high quality care. So my point exactly is that without leadership, like Dr. says, the center or the glue that holds these process initiatives that are targeted towards improvements or survival for organizations, including healthcare, are all anchored in good leadership. So And that is why you see the standard for 901 2015 has a focus in terms of and chapter 5 that talks about leadership and has got 3 sub clauses and has got 6 statements that refers to issues shall, which is basically a requirement, and has got 1 documentation that is required in terms of the quality policy in 5.22. So there are a number of things that this particular section alludes to. So top leadership shall demonstrate leadership and commitment with respect to the quality management system by taking accountability of the effectiveness of the QMS. And there are a number of issues that are listed down there in terms of the things that management must give certain commitments to. And it's not just commitment, they must demonstrate that particular commitment. And that is our excitement as PCH Ogoria Hospital. The compatible strategies and objectives that Dr. Kimemia talked about, the communications that are supposed to be made in terms of the policy, ensuring that the system, he talks about the strategy, and this strategy must be integrated within the business processes of the organization, including PCH Ogoria Hospital, promoting awareness of the process, among other things that are there. So the culture of continual improvement is something that is at the heart of PCH Ogoria Hospital in terms of its strategic plan. We made sure that we put it there to integrate quality improvement in services offered within PCH Ogoria Hospital. So the rest are basically still also the requirements that the standards put in terms of what is a requirement that we need to be able to fulfill, but it has got good recommendation for leadership for quality improvement. So if you just look at that section in your own time, you'll be able to find good advice that would be able to tell us how we can be able to achieve leadership for quality improvement. Quality improvement requires vision, the leadership, and the persistence. It's not something that you say that it's a one-off thing. It's not an event. There is always room for improvement, and that is what we make sure that we do. And in terms of vision, this vision requires leadership for us to be able to implement it. And the leadership that's supposed to implement this particular vision requires to be persistent in terms of achieving that particular vision. So the real challenge that we find ourselves in is that it becomes very difficult for us to be able to develop leadership skills throughout the organization. Sometimes we localize the leadership to just top management, the CEO, and I heard Dr. Kimemia talk about the people perceiving leadership to be the CEO or unit heads or just people at the top. But we have people who are passionate about small quality improvement strategies or small quality improvement initiatives that would help turn around the organizations that we work for. So the other thing that we must also be able to find here is that quality is very simple. There are those very simple needs that we are supposed to implement or change, yet they are very complicated at the same time. Sometimes simple things like just hand washing, just making sure that while you walk into a place that is sterile, you have hand washed before touching a patient, after touching a patient. They're simple initiatives, but they have huge cost-cutting measures that organizations can be able to employ. A good example is when you don't wash your hands, a simple initiative, the next step is that you will end up having hospital-acquired infection for patients who ordinarily would not be unwell. So the other thing is that in as much as this is very true, there's small, simple principles that are being taught over and over that have been said. These are not new things. They're things that we have heard over and over and again, but sometimes it becomes very complicated and difficult to be able to implement them. And that is why the standard ISO 901 refers to commitment of leadership and demonstration of those particular leadership, as opposed to basically just talking about knowledge and reality. You see, these two sometimes get disconnected in terms of what we do and what we practice and the amount of knowledge. And this disconnect can only be cured by the commitment of senior leadership as a necessary ingredient for the success of the initiatives of quality improvement. So Chogoria Hospital has done a number of things in terms of quality improvement. We have started from the basics of the 5 S's, the audits, and these are simple things that sometimes organizations, as they grow, they ignore the simple things that made them where they are. So this is something that we as a hospital still retain, because it was the founding steps that would be able to help us to be able to reach the point where certain departments of our hospital has also become ISO accredited. So we have developed other documentations for quality management system. We have done that. We have worked closely with the Christian Health Association of Kenya, CHAK. It had an initiative for quality officers. And because of the initiative of CHAK, that is how Chogoria Hospital was able to employ a quality improvement officer. And a number of other hospitals that are affiliated to CHAK have also employed quality officers that have initiated quality improvement interventions and activities and strategies in their various hospitals. We have formulated various policies, manuals that are guiding us, and we have also done a number of procedures and also a number of algorithms, the flow charts that we need to do, the treatment manuals that would now guide the standard of care within our facility. So we have also helped as a committee for quality improvement team. So a quality improvement team has got various subcommittees, which I'll mention in a short while. But our quality improvement team also believes in what is called integrated management, that also has got a focus on also looking at key performance indicators of the hospital and evaluating how the hospital is performing in terms of its service delivery. The mortality rates, the hospital bed stays, admissions. So those indicators are things that we are looking at and reporting those particular activities. We also conduct regular M&Ms. We have, and I have a special interest in this activity that we have done, in the belief of what is called lean hospitals. We have developed a criteria of getting items that are in use, items that are rarely in use, and those ones that will never be in use. So the hospital took an initiative to be able to assess things that are dumped in corners and dumped in dark areas, places that sometimes are never used. And these items, when we auctioned them, they were able to help in the rehabilitation, construction, and roofing of one of the units. And I'll not say here because we don't know who is here, but it helped us to be able to do this kind of an improvement. So this is something that is important to us and show the power of little improvements that are within our facility. So we have also introduced a quality award within the hospital. So the units that are doing very well in terms of quality standards that we have initiated in a very open and transparent manner, we have rewarded these particular units within the hospital. We have started doing incident reporting and audits that we've also done. And something else that is also very important is the integration or introduction of quality management in procurement processes. This is something that within the mission hospital has become a problem, because part of the things when it now comes to procurement, sometimes we end up with disposal. The procurement committee dealing with disposal of items that sometimes are donated to hospitals without following quality checks, compatibility of power sockets, among other things, with the donated items. Some of them either are used or not used, or they just occupy space, or they're just dumped within our hospitals. So these kind of things have now allowed the processes of quality improvement to be able to make sure that the items that are also brought are within the specifications and qualities that we have specified as an organization. So the other things are basically issues patient safety, which is also a subcommittee within the quality improvement team of our hospital, which also handles issues infection prevention. We also have a medicine and therapeutics committee that also looks at all these issues about drug management and also reporting of medical error. So this is something that we also do. So the rest are also medical issues of customer satisfaction, which there are several interventions that we've done to be able to make sure that the customers are comfortable. Basically domesticating the MOH patient's charter and rights. And these things take a huge leadership commitment to make sure that these things happen. like Dr. Lilei was saying, that some of these initiatives provides opportunity for witch hunt, for gossip, for things that are not within the process, or things that would make the process not to be able to move forward in terms of quality improvement. But when the process is fair, is transparent, and it is communicated in the language that the organization understands, then it becomes part of their culture and it becomes part of their normal practices. And this is what we believe in. And this, when you look at the 7 points of quality as a hospital, and these things are the things we believe in, they basically refer to the leadership, and this is our business model. So when you look at the quality as an attribute that would distinct us from other healthcare organizations, that would reflect us as the maker of this particular product or service that we offer, that would make this quality service the brand that we want to be able to be associated with, that will be able to build this as a 21st century business model in terms of quality, and to be able to have this as an attitude. And Lele talked about the culture of quality. So this is something that we hold very dear to us. And also, quality is not just one person. It's not leadership at the top. It is also leadership of the healthcare workers, leadership by the foot soldiers, the people who believe in this kind of activities and works and interventions, and basically that this all is basically planned. It's not an event. It just doesn't happen. It is caused to happen. So this is something that PCH Ogoria Hospital believes in, and I have no other much comments to be able to give. I've given you my experience in terms of the quality initiatives that Chogoria has undertaken as a faith-based institution. I've also given you my thoughts in terms of leadership in quality improvement. Thank you very much.
Thank you, Milano Cheng, for that wonderful presentation. And we're excited to see what you've been doing at Chogoria. It's quite good work. And we're also excited to see that your leadership has been actively involved. We do agree that quality improvement is not simple. It looks simple, but it is very complicated. Santi, for that presentation. Now, we have 10 minutes to the end of our session, and I'd like us to just go through a few questions, Q&A. And I'll start with the questions. I hope all the participants are there. And my first question goes to Dr. Kerry and Dr. Panga. This is about the experience in Nanyuki. I'd also like Dr. Lele and Milan to chip into this one. This is about, my question is, in the facilities that you've worked with, Milan and Dr. Lele, you're currently working in facilities, but Dr. Kerry has been doing projects with facilities from Nanyuki and Laikipia. How proactive or receptive was the leadership? And by leadership, I'm talking about the top management. I know everyone is a leader in their own individual capacity or collective capacity. But when it comes to top management, when you approach them with the idea, how supportive or receptive were they? And this goes to the issue of sustainability. After you finished your project, after you finished everything, you wrapped up and you moved on to another facility, did the change idea still remain? Was it sustainable, or did it die immediately your team left off? So Dr. Kerry, we'd love to hear from you, and Dr. Panga.
Thank you, Rhoda. I think we were very fortunate. It's our philosophy that we grow everything together. So the idea for what we were doing really came as a joint idea with Dr. Kilonzo, who was the medical superintendent, and Dr. Panga, who at the time was Chief Officer of Health in the county. So we had their engagement right at the beginning. And interestingly, in our first Springboard course, we included members from the county, as well as from the county government Ministry of Health, as well as from the hospital, so that this was a process of growth that was going to go together, and that there were people in high leadership positions who really understood what we were trying to do. But Dr. Panga would be better perhaps to speak on this. if he's there. Can you speak?
Thank you so much. Yes, yes, it's true. It's true that at the level of the CEC back then, for the long journey that we started, there was a direct ownership of quality improvement as a way of working. And really that helps because it marshals everybody in that direction. And it also enabled us to perform other partnership activities and to allow people with different skills, I think we even had someone who just, a doctor who had gone and specialized in flow management, like an engineering issue, actually, engineering in healthcare. And those people who are coming and joining us out of this goodwill enable us to look in depth into our hospital, look into our systems, look into our the common small wins that we need to have in the department, and enabling people from different departments to talk to each other and have common goals. Yes, of course, we did not achieve everything, like we've had from Chogoria, where through CHAC, they found a compliance system of having a quality lead in the management, if I understood. So we have a bit of journey that we need to complete, and I'm sure we are going to improve and be better.
Thank you for that, Dr. Panga and Dr. Kerry Jones. My next question is to Milan and Dr. Lele. And I've seen you've done quite commendable work at your facilities. The leadership support is something that you brought out very clearly from the topic. My question to you is, due to the accreditation and certification framework that we have. Initially, Dr. Lele, you said quality was an issue of NHIF at the beginning, but now people are taking it a bit more differently and looking at it as a way of life. Milan has also talked out very clearly about the ISO 9001 in 2015. So my question is, how can we encourage facilities that are not yet looking to certification and accreditation to support quality improvement? Because once you get into the quality management system, you'll find that due to the regulations that are put there, you have to have this as an indicator, you have to have audits that are being done, you have to have a system of improvement, you get gaps, you have to do corrective action, preventive action, all those things that come with the audits from NHIF and from other bodies. So how can we get facilities, more so in the public sector or faith-based organization or private sector, that are not yet into the framework of accreditation or certification, to slowly start embracing quality improvement?
Let me start by saying, as a hospital, we are actually yet to go through any certification or accreditation. But one of the ways that I look at quality between the assurance and the improvement is it's a continuum. I look at it as the quality assurance aspect. There's certification, the accreditation, as what you'd probably consider as twofold, either a bare minimum upon which you must be, like this is the minimum you need to be. And the second way to look at it is like a big brother, just coming to make sure that you are on the right path. And even as, because we are beginning to think about going through an accreditation process, even how it is sold to the facility or how it is communicated to institutions is, this is not a tick. It's not you're not checking boxes. I feel like it should be communicated as one of the tools
that can be used to entrench within the institution a culture of quality improvement. Because that should be, I think, our ultimate goal. Our ultimate goal should be continuous and consistent quality improvement at micro level all the way to at macro level. And I think that accreditation and certification should be sold as one of the tools to help you meet that goal and objective. Thank you.
Thank you for that response, Dr. Lelai. Yes, Milan?
Yeah. On my part, I think I have two approaches to this. One is basically in terms of how, aside from where Dr. Lelai has left, on how we sell the buying point to the people who need to have a buy-in for this kind of strategies. One is that how do we involve the leaders? Because once the leaders have got a buy-in, then the populace or the people working under them will be able to see the vision that the leaders want them to be able to follow. And in terms of selling this to the leaders, one thing that has worked well for us is to engage the leaders right from the onset. When these kind of interventions are brought to us, sometimes they look very foreign. They look like things that are supposed to be practiced abroad, but not at home. But once we have engaged the leadership right from the onset, they be part of the processes, we delegate responsibilities and task them to be able to deliver certain responsibilities within the introduction framework for quality improvement, then they will be able to slowly take responsibility and own the processes, working together with the quality leads within those particular institutions. The other thing that is also important is to be able to let the people or let the leaders and the people who work under them to be able to see the benefits of quality intervention and the effects of the ignorance of not to intervene, not to be able to implement quality intervention. So in the absence of quality intervention, this is the risks that are involved, and this is the cost. Sometimes we can even go to the level of costing the risks that are involved, and then they'll be able to see the damage that the avoidance of implementing quality intervention would be able to cause. The second one is basically at a way broader macro level in terms of national framework. At the moment, quality is being regulated to a large extent by amorphous bodies within the Ministry of Health. Here we are talking about sections of it by regulators, section of it by NHIF, section of it by MOH, and other interested players, say the partners that are funding organizations. When they fund, for example, CCC, then there are quality improvement interventions that are basically expected of them. So these quality interventions are things that you see how these particular partners are directing or forcing us to be able to behave in a manner that we needed to have behaved right from the wide go. But this is this becomes a cost by the external players as opposed to homegrown or inbuilt mechanisms. So if we could have at the Ministry of Health, say, have a quality and standard body that would tie elements of reimbursement of NHIF to quality standards and expectations, and also licensure according to those quality standards and expectations, then we will be able to cause both public and private alike to be able to act on issues quality and also to the benefits of the patients. So for me, that is how I look at it. And also the small interventions that have been done in terms of quality provides a window for the top leadership to be able to learn from them, and then they gain acceptance for a wider scale activities. And I'll give you the example of Chogoria. The reason why there is a wider acceptance by the hospital leadership is that because we started with the lab being ISO 15189 2012 accredited, and that gave them an experience because that was part of a process that was also a requirement by the regulator at that time to be able to make sure that that process gave them a learning experience to be able to have this support for the wider hospital quality initiatives.
Thank you very much, Milan, for that response. And I agree with you. This should start from the national level. And maybe if we do cost the risks, Dr. Lele also talked about it being a way of life, not being something that is pegged to accreditation or certification. And my next question goes to Frederick Kimemia. And Frederick, there's something that Dr. Lele brought out in a presentation about culture, leadership and culture. So my question is towards healthcare culture. The current culture that we see in our health system is a culture of defensiveness and secrecy. You talked about looking at the customer's needs or the client's needs. So whenever a customer complains or whenever a customer raises a concern, you'll find there's a bit of defensiveness and secrecy. There's a blame culture. We're looking at who's at fault. Was it the nurse? Was it the doctor? Was it the lab person who delayed or who did not do their part? And this culture, the blame culture, is very alive and actively breathing in our healthcare system. And then also there's action on the non-risk or action on any gaps that are identified is usually very slow. We might be able to identify an area or an opportunity for improvement, but we find that we're very slow to act. Then most of the challenges or events that occur at the front line are rarely reported to the leadership or to the management level. And the failure to learn from our mistakes. If we commit a mistake or if a mistake happens this year, you'll find again sometime maybe next year, somebody else will repeat the same mistake. So failure to learn from our mistake. So my question to you, Frederick Kimemia, is maybe you can make a comment on culture and how deeply ingrained it is in our organizations, in our health facilities, and what the leadership can do to change the culture and introduce the concept of quality improvement as a wholesome and continuous way of life in the organizations.
Thank you. I think it's a difficult thing, and Dr. Lele brought it up, the issue of culture, and culture is not about being Kikuyu or Laluyo or Laluya, but it's those beliefs and practices that are happening sometimes silently within the organizations and our structures, and some of which has are detrimental to quality and quality standards for organizations. And I'll give an example, like you said. I remember going down to, I will not say which county, but I went to county to follow up on a mother who had died. And she had died in a tucked up place right inside 200 kilometers from the main county headquarters. And I met a girl who had died while giving birth. And the reason that's why she died is because she had a difficult delivery at home. The placenta was in her uterus for about 3 days. So she had an infection. When she went to a facility, they were not able to remove it. So she was sent to the county referral hospital. So I followed up that woman from right down from her home. It's a place called Daba, tucked up in Isiolo. And then I followed her to Archers. She went to Archers, a health center. And then she was referred to the county headquarters. When I went and I met the ops guy, the ops guy who is in charge in that facility, I asked him whether he knew of that case. And I remember what he said that almost made me cry. I'm a man and I'm not supposed to be crying, but he told me, women die here every day. So that's what he said, and he's an ops guy, and I don't want to say which one, because I know he's still my friend, but he said, women die here every day. So, and actually that is a culture. So when you say, what is culture in healthcare organization is when a healthcare worker says that women die here every day, or kids die out of malaria, or women deliver in outside the hospital every time, or women deliver in the vehicles where they're being transported every day. So that is now what you're saying, culture. And Dr. Lele said, when you think about leadership addressing that, it's sort of like a hard, very, very hard thing to do. The reason that's why it is hard, because then that's the soul of a person. Sometimes that is that person, you either kill them or you throw them out. But if you do that for everybody in healthcare setting, you will be left with almost half of the population of healthcare workers we have, or maybe 3/4. You'll be left with a quarter of genuine, honest, merciful, empathetic healthcare workers. So now the challenge of leaders is now to turn those negative beliefs and practices of healthcare workers into the kind of loyal sworn soldiers of quality, which is very, very hard. Not unless you as a leader or as a manager in that hospital decides to recruit the best, to enforce the best practices. It will probably take ages, it's probably take years. Sometimes you're hired, you're fired before you are able to achieve what you want to do. But as leaders, I think we have the mandate now to look for people who believe in quality and make them, put them in position where they can influence quality in the hospital. Again, it's very, very hard. It's only God who knows the heart of people. It's God who makes people change. Maybe by putting laws and firing people may not help. Maybe how about focusing on the positives and enforcing on quality practices, celebrating those who stand for quality honestly, not just celebrating, but making sure that we have the right people in the right places and honor the right people. The problem is sometimes you come up with a quality program, like the one I was talking about in the country. We have a Kenya Health Quality Award. It's a very nice strategy, but show me the tools, how you are honestly and through transparency coming up with the best practices. So because we will be living in a system where people are honestly honored, honestly celebrated. We do not put people in leadership who are thugs. We do not put in people in leadership who do not support quality. We do not appoint people in management positions who do not care. Sorry to say, because I've seen people saying, I do not care, patients die here every day, or that patient was not raped, or that patient was not done this. And then you defend, you do not stand for the best practice. So Dr. Lele, I think, and the rest who have the same feeling that we have to enforce on a culture that is celebrating quality. And I think it's, if we were to focus on all any other programs, if I would ask to prioritize what is important, should be now focusing on quality. Any other thing else, including financing, including workforce, every other aspect of health system is anchored in quality. If we cannot assure quality in the way we do our things, we are probably doomed as a fraternity, because then what do we stand for? If you don't stand for patients being treated right, we do not stand for the best of healthcare. We do not push for improvement of our practices. If we do not stand for that, then what do we stand for? And I think that's my take on it.
Thank you very much, Frederick, for that response. And I agree with you, culture is not easy. There's a comment from Tolbert Maina saying, thank you for the wonderful presentation. I think the issue of culture in health workers should start from the first day of orientation. Should it start from when you get to the field, or should it start from the classroom? I don't know. That's a topic, or that's a point to ponder as we continue. Should it start in our informative years when we're being trained, or should it start once we go to the facility level? I'd like to thank all the presenters who found time to come talk to us. We have one of the people who was going to present to us, but she'll be presenting to us tomorrow as the main speaker, Emily Omari from Kikuyu, and we're excited to hear. It will be a continuation of this topic. It seems to have generated quite a lot of interest. It's good to hear what your neighbors are doing. It's good to hear what the other facilities are doing. It's good to see that people are starting small and building up on it. So thank you, Emily, for honoring our request to present in tomorrow's session. We appreciate you for that. So a few comments. I've seen somebody saying, I've seen a situation where leaders have reduced noble health service to individual interest and for specific people, which compromises the quality of health services. Thank you for that comment. I've seen somebody who's also saying leaders should not respond negatively. Somebody else has said every organization. Jane Otipa says great presentation, very important information being shared here. Every organization needs to hear this. Dr. Kimemia, there's a question about when the energy levels of your sworn continuous quality improvement soldiers go down. How do we motivate them to continue going forward, to continue striving for change, to continue preaching the gospel of quality improvement and doing the best to their ability? Dr. Kimemia?
Oh, sorry. I feel for you because there are so many stories of people who are almost giving up. And some of us have given up in many instances. But the thing is, with issues of quality, it's either there is if you're sworn believer of quality, chances are that you will not accept anything below what you believe in. It's because quality and standards it's our personal commitment. So if an organization doesn't recognize that, and I think we've had examples of people who've moved across organizations. I have had to move between an organization with another based on issues of standard. And I remember my last point I moved, I was earning, no, let me not say what I was earning, but I moved because my manager standard was very low, and I communicated that to her many times. So then it came to a point I said, I cannot take this because your standard is this level, her standard is this level. So I think sometimes instead of killing yourself, find for opportunities all the time. If you're good and you're very good at what you do, for sure you'll find an organization where people understand what you stand for. Because I think if an organization is not meeting your personal goals, also you can be working against all the energy you have. The best is to look for organizations that are prescribed to what you believe in. If there are very few, then it shows our status of healthcare is low, because I believe all organizations should be working towards the best of standards, because best of standards and best of quality is equal to a better organization. That is for a fact. If an organization believes in quality and high standards, then it means then in terms of the industry, they are one of the best organizations. So just move. Me, I will not encourage anyone to continue struggling and suffering. When you believe, you know what you believe in, just work on transitioning out. Believe in the best of you, always stand for your best, always stand for the best of quality up to your deathbed. Let you walk out of this world to the other with us knowing that what you stood for. What you stood for, stand for it. Other healthcare workers, healthcare managers, they may do what they want to do. That is their choice. Please make sure that you choose what is best. And you'll find people like Kerry. I was listening to her and I said, what an awesome journey. We have people who have believed in the best of everyone. So you will find people in organizations that believe in what you believe in. So thank you.
Thank you, Dr. Kimemia, for that response. This brings us to the end of our session. I'd like to thank all the participants who attended today. I believe today we were speaking to current and future leaders in healthcare. No matter what cadre you are from, you're a leader in your own way. And quality improvement is not just about the facility. Sometimes it's also just starts at home. Small changes here and there. If we look at the Kaizen that Milan presented, it's something that we can adopt in our setup at home. So thank you very much, the future leaders. You have a big role and a big task. We all have a big task ahead of us to create an enabling environment for quality improvement in healthcare. Let us not find a facility the way it was and continue with the status quo. Let us look at how we can improve. Let us look at how we can give the staff a voice, staff who work there, from the most junior to the most senior staff. how do we give them a voice? How do we make them be able to talk about their ideas and suggestions? Because that is where we'll see room for improvement. The way the security personnel or the person who cleans the floor interacts with the staff is very different from the way the CEO will interact. They'll probably be able to hear the patient complaints more and better and see how to improve the situation. So let us be able to create and give voice to our staff. Let's find opportunities to train them. Don't just nominate the top leaders for training every single time. Train that frontline worker because they're the future leader. When you retire, they're the ones who will get into that position. So create opportunities for them to also get training, to also learn, to grow, and to be able to provide quality healthcare, such that 20 years from now, when you come back to that facility seeking service, you're very sure you're going to get the best because you invested in the staff at that time. Let us look for opportunities of motivating our staff. Once we in the position where you don't have to be a leader to motivate your colleague. So let us look for opportunities to motivate each other and to find joy at work, to enjoy coming to work. We have a few people who probably go to work because they have to earn a living. They don't enjoy what they do. So let us find ways of motivating each other and pulling each other to enjoy what we do on a day-to-day basis, because that is where now the patient will be able to feel our impact and appreciate us. Then there's the issue about celebrating staff and rewarding them and just celebrating the small wins. It doesn't have to be a major intervention that you've done. It could be small, but let's celebrate our wins. I'll end this with two comments that I've seen. Somebody saying, I strongly believe it is important for all high leadership in health planning and directors, medical services, and chief officers in health to get training on quality management. That is true. It should start from the leadership level, but it should also roll down because the current junior most staff is the future leader. So let's create a system of training everyone in quality management. There's also another comment on strengthening the voice for all, no leaving one behind. So let's not leave each other behind. Everybody should be able to move the quality journey together. I'd like to thank the organizers of this session, Quality Improvement Unit from KNH. Thank you very much for the leadership that you've shown, and thank you for finding us very able presenters. I'd like to thank the presenters, Dr. Kerry Jones, Dr. Timothy Panga, Dr. Frederick Kimemia, Dr. Faith Lelei, and we prophesy, Dr. Milano Cheng. Thank you. Thank you very much for finding time. And I'd like to also let you know today is World Psoriasis Day. The Kenya Dermatology Association of Kenya will be having a session at night from 7 p.m. using the same link, and they'll be telling us more about World Psoriasis Day. What is psoriasis? The theme for the World Psoriasis Day is Be Informed. So that is a very good session for us to attend and to learn more so that we don't misdiagnose our patients. Log in, learn more. You can see the panelists there. We have Dr. Ozaya Waweru, our able CEO, Dr. Evanson Kamuri will also be one of the consultant dermatologists who will be speaking, Dr. Rup Saini and Dr. Jacqueline Kavete. Those will be the presenters for tonight's session. Karibu sana. Tomorrow we have our last session on Quality Improvement Week. It will be a continuation of today's conversation. We'll have Emily Omari talking to us. We'll have Dr. Mary Adams, and we'll have Miss Linda Okoth talking to us in tomorrow's final session. Karibuni sana, and let us know your feedback, whether you'd like to have a similar session again, and what your take-home points. Tomorrow we'll be looking forward to getting feedback from you on the take-home points. And once again, I repeat, if you'd like to come and learn more about quality improvement, kindly write to KNH Research, and they'll be able to link you with the unit that has organized this session. Asanteni sana and have a great afternoon. God bless you.